So we are going to record the session as usual. You might get a little prompt on the screen, so just acknowledge that. But welcome everybody to Grand Rounds for this week. It's my honor to introduce our featured speaker today, Dr. Jeannie Bailey. So Dr. Bailey is a PhD researcher in our department and an assistant professor of orthopedic surgery. She did her undergraduate work at UC Berkeley and then received her PhD at the University of Washington in bioanthropology and anatomy. And then she came to UCSF to complete her postdoc, and then following that has stayed on as faculty. And she's really had a number of accomplishments so far, including an early investigator award from the ORS spine section, the ISSLS prize for bioengineering science, and she also received the outstanding paper award in the spine journal from the North American Spine Society. She's done research on looking at factors predicting outcomes in different spine conditions, looking at the effects of muscle quality on outcomes from spine procedures, as well as some really interesting work involving NASA and space medicine. With that, I would like to welcome Dr. Bailey, and Jeannie, thanks so much for presenting and look forward to your talk today.
Thanks. So today I'm going to go over a broad overview of my research concerning muscle health, patient-specific biomechanical behaviors, and digital technology. And hopefully I'll convince you all that those are somehow tied together. My disclosures include some consulting work for startups, including Hinge Health and Bionics. And so going back to these three topics that sort of transcend my research, and for the most part today, muscle health refers to multifidus muscle health, and patient-specific biomechanics is spine patient-specific biomechanics. So it's mostly low back pain related for today. But I want to give an overview of past, present, and future studies that I am working on, completing as well, that sort of transcend these ideas and hopefully convince you that they are related in terms of ortho care. And so to start off, I want to give an overview of our NASA project that Drew mentioned, which is coming to an end. And it was an arduous 8-year-long endeavor for a very small sample size. But the final report is due in 6 months, so we're frantically publishing everything now. And so why do us orthopedic researchers care about spaceflight? Well, spaceflight leads to a heightened incidence of low back pain and disc herniation in astronauts following spaceflight. During spaceflight, astronauts have a high incidence of something called space adaptational low back pain, where they have pretty moderate low back pain within the first week or so being in prolonged microgravity, but that generally subsides. And then in a completely different situation, they come back and have heightened incidence of disc herniation that can occur even years later after spaceflight. And along with this, chronic low back pain often continues for them. And so in addition, spaceflight provides us a nearly perfect experiment for investigating this problematic structure function change that is occurring in the lumbar spine during prolonged unloading. And this work was initially sought after by Jeff Lotz and our collaborator Alan Hargens at UCSD, who attained the grant about a decade ago. And so to really understand what's going on into the lumbar spine in space, we need to consider all the key players. The structural elements of the spine that are being affected include the intervertebral disc. And it's been long hypothesized that this is the main culprit because going into space, you have prolonged unloading. It's thought that the disc imbibes fluid without any gravitational resistance, so it supraswells, comes back with more hydration, creating risk for disc herniation. That was the initial hypothesis. But in addition to that, spaceflight undoubtedly affects muscle atrophy, muscle quality, with the unloading. And spaceflight, with our astronauts, the average age is 40 to 60 years old. So age-occurring pathology and degeneration in the spine is undoubtedly a characteristic as well that is creating problems. As for the natural biomechanical function of the lumbar spine that's being disrupted in space, here on Earth, our lumbar spine is built for load bearing and controlling motion between the trunk and the lower extremities. So these are the functions that are being disrupted primarily following spaceflight. So with all this in mind, we hypothesized that biomechanical changes following spaceflight relate to risk for disc herniation, and that these structural elements of the lumbar spine contribute to the biomechanical changes, and they may be predictive of who is at risk for disc herniation following spaceflight. And so in our study, we have an N of 12, mostly male, NASA astronauts, average age of 51. And we collected advanced imaging and clinical outcomes data at 3 time points. Pre-flight, so sometime within the year preceding them going to space for 6 months. And then we had a post-flight time point of data collection sometime 2 days to 7 days after they returned to Earth. And then we had a recovery time point 30 to 60 days after they returned to Earth. And we collected data from 3T MRI, looking at spinal pathology, including facet arthropathy, in-plate irregularities, high-intensity zones, and of course, disc herniation. We also looked at disc factors, including degeneration from Furman grade and water content from T2 mapping. And then we looked at multifidus for throughout the lumbar spine. And we looked at it for total cross-sectional area, muscle-only cross-sectional area, and then the percent of muscle that was within the total cross-sectional area. And I might occasionally refer to that as muscle quality during this talk. We also looked at spine segment kinematics using quantitative fluoroscopy, and we quantified the maximum range of motion of each lumbar segment in flexion extension, lateral bending, and the amount that it translated during these motions. So moving straight into our results, what we found is that 50% of our crew had returned from space and had a symptomatic disc protrusion or herniation. And so that means that they either had a completely new disc herniation on their MRI that went along with related symptoms, or that they had new symptoms of an existing asymptomatic herniation. And here's an example of a disc herniation from one of our crew that occurred between the immediate post-flight and the recovery time point, showing a herniation at L4, L5. And credit goes to Connor O'Neill, who is a co-I on this study and did all of our pathological scoring. And so if anything's wrong on here, we can blame him. So looking at the hydration of the disc and how that changed following spaceflight, what we found is that there was really no consistent relationship between any changes in disc hydration or health following space. So if you look here, this is just percent changes for each disc that we looked at in our 12 crew. And we found that if we stratify by level, half lost water, half gained water. And then furthermore, if we look at subjects with disc herniation in orange, subjects who had a disc herniation following spaceflight, who are in orange, versus those that did not, there was no consistent relationship of whether or not they increased or decreased in water content. And then pink is specifically the levels that had a disc herniation. Some decreased in water, some increased. And then similarly, when we stratified by Furman grade, we also didn't see a consistent pattern of change for disc hydration. And we looked at disc hydration using a lot of different statistics as well to make sure there was nothing we were missing. However, muscle, on the other hand, did show some interesting changes. So for total cross-sectional area, throughout the lumbar spine, we saw that at L4, L5, there was a decrease following spaceflight, but it recovered. Similarly, for the muscle-only cross-sectional area, for the lower lumbar spine, it decreased in cross-sectional area, but it also recovered. And then for muscle percent, it also was affected by spaceflight, and it also recovered. However, oh, and here's an example of how that can maybe look in some of the crew. Here we see, this is multifidus on the left side at L4, L5. And the gray is the lean muscle, and the colored part is the fat or fibrotic tissue. And we see that for this particular muscle, when it came back from space, the distribution of fat and fibrotic tissue was more spread out. And then it kind of returned back to what it looked like pre-flight at the recovery time point. And all this muscle work was done by 2 trainees, Priya and Gabe. However, that's not the end of the story for muscle. When we separated our crew based on who had a disc herniation versus who did not following spaceflight, we found that for those that had a disc herniation, which here is each level of the lumbar spine separated by individuals who had a disc herniation, so all the orange, versus those that did not, so all the blue. And this is transcending the 3 time points. And what we found is if we look at the subjects who had a disc herniation, that in the lower lumbar spine, they had a significant decrease in muscle quality. But those that did not have a disc herniation did not have this change in muscle that we saw in the pooled statistics. And then furthermore, these disc herniation subjects had a pretty stark increase in asymmetry of their muscle quality at L4, L5. And it seems a similar pattern at 3 and 4, but that was not statistically significant. So we see that these muscle changes are primarily occurring in the disc herniation subjects. However, what's going on for the kinematics? Well, for maximum flexion extension range of motion, we found that in the upper segments of the lumbar spine for L2, L3, and L3, L4, there was a significant decrease in range of motion following spaceflight. And interestingly enough, this change in kinematics seems to be related to whether or not someone had pre-existing in-plate pathology. So in-plate pathology was the key pathology that we found kind of throughout our crew. There was ample amounts of it. And just for the record, none of the spine pathology that we measured changed following spaceflight or got worse. So a lot of it is looking at what was pre-existing and what might have created problems. So in those who had pre-existing in-plate pathology, we found that there was these decreases in flexion extension range of motion. So all the orange here are levels with in-plate pathology throughout the spine. And we see that they're mainly on the loss of range of motion side of the plot compared to those who did not have in-plate pathology. So in-plate pathology coincided with the 20% decrease in segmental range of motion following spaceflight. But for those that didn't have, for segments without in-plate pathology, we didn't see any changes in stiffness following spaceflight. And as it so happens, these in-plate pathologies for our crew were most prevalent in the upper lumbar spine, with only a few that were present in the lower half. So we conclude that the existence of these in-plate pathologies, which are primarily in the upper part of the lumbar spine, are leading to stiffness in the upper lumbar spine following spaceflight in crew that have them. And so what are factors that we found that associate with disc herniation following spaceflight? We found that there's decreased range of motion in the upper lumbar spine that associates with in-plate irregularities. We found that pre-flight, subjects with lower multifidus quality and higher multifidus asymmetry were at heightened risk for disc herniation. Furthermore, that these subjects also had a significant decrease in muscle quality and asymmetry, primarily in the lower lumbar spine, and that there were no pre-flight risk factors necessarily for water content or muscle area or other spinal pathologies. So what does this mean for mechanisms for why disc herniation happens in astronauts? Well, we think that there's regional differences that are affected by microgravity on the lumbar spine, with increased stiffness occurring in the upper lumbar spine that associates with in-plate irregularities, as well as decreased muscle quality in the lower lumbar spine. And that's where all the disc herniations happened for our crew, was in the lower lumbar spine segments. So we think there might be kind of a big adjacent segment disorder that's kind of happening, where a lot of the stiffness that's happening post-spaceflight is in one section and creating unfavorable biomechanical conditions, maybe in the lower part, creating risk for disc herniation. And so our pre-flight risk factors that we can kind of identify from this are mainly spinal pathology, so in-plate irregularities, and muscle quality. And these are things that we're working with NASA to hopefully try to create like surveillance of to understand if they really are risk factors. And furthermore, can countermeasure exercises in space protect crew from disc herniation? We don't know, but this is something that we are working on. So here at UCSF, now that the astronaut studies ended, there is a different patient population that we can kind of take a similar approach to understand risk for problems with longitudinal changes in their biomechanics, and that is our lower extremity amputee population. We do a lot of osteo-integrated work, which is a unique surgery and not commonly done on civilians, but we have some cool trials here going on with transfemoral osseointegration. And osseointegration is a pretty arduous undertaking because it's a two-stage surgery that goes over a whole year. So there's a long period of time of unloading on the affected limb. And no one's really looked at the muscle quality of the hip muscles that are affected by this prolonged unloading. And so just looking at the sparse clinical scans available, you can see that, even though I know the resolution's not great, you can see that on the affected side, the hip stabilizing muscles, like the glutes and things, they're smaller and they have a lot more fat infiltration. You can see it pretty clearly here. This looks pretty infiltrated. But why do we care? Well, last year, one of our patients, very surprisingly, needed a hip replacement after they had the implant. And so they already had this implant right here. Oops, sorry, right here. And then they needed a hip replacement. And as you can see, that hip replacement barely fit. There's about 1 millimeter, I think, of room in the femur. And so if that wasn't possible, I don't know what her options would have been besides maybe pain for the rest of her life. So more work needs to be done on whether or not changes in muscle quality associated with osseointegration might actually be like increasing risk of needing a hip replacement on the same limb later in life, because that would not be a good situation. So right now we have a DoD funded study to look at this specifically. How is the hip muscle quality affected by osseointegration, and what are the biomechanical ramifications? And then we're also looking at low back pain. And so low back pain is the most common secondary complaint in lower extremity amputees. It affects 52 to 89% of them after their amputation. And here's a example of a MRI from one of our osteo-integrated amputees that recently developed low back pain after 40 years of already being an amputee. And you can see his spine is pretty degenerated with bridged osteophytes right here. But he also has some very neat in-plate pathology and very apparent muscle fat infiltration on the affected side. He's a very severe case, but what we want to do and what we've proposed to do is to use amputees in general, similarly to astronauts, to track changes. So we want to understand what are risk factors for why a low back pain patient would go from acute to chronic, so we can follow these amputees when they become acute after their surgery and see what are risk factors within their spines or within their biomechanical behavior that might create risk for going on to be chronic and not getting better before that point. And if we can figure that out, we can probably understand a little bit more about what creates chronic low back pain. And a lot of this amputee work obviously wouldn't be possible without Richard O'Donnell, who spearheads a lot of the research on it. And so going back to my plot, we also have a lot of research on muscle quality and low back pain. That a lot of it has spurred from the NASA work, because we need to understand what is going on with muscles in regard to low back pain. One of the most common ways we look at muscle health in our patients is using MRI. And the most frequently used method includes using clinical MRIs, which are pretty unpreferable, but they are readily available. And so if you use clinical MRIs to try to understand muscle quality, it requires a lot of post-processing because you basically have to threshold the muscle, as you can see here in these two different thresholding methods, in order to separate what is lean muscle from what is not lean muscle. And what can be not lean muscle isn't necessarily fat. It can be fibrotic tissue. We don't know. So it has a lot of laborious elements to the post-processing and a lot of inaccuracy. Fortunately, here at UCSF, we have fancy sequences for predicting fat infiltration in our muscles from MRI, primarily IDEAL, which gives us an accurate measure of fat pixels within an MRI. So here we can use it to understand exactly what is the percent fat within a region of interest within an MRI scan. And this work would not be possible without our IDEAL guru, Roland Krug, in radiology. And so now that we're able to estimate muscle health from MRI accurately, why do we care? Well, multifidus muscle health is thought to be very important for chronic low back pain. But one thing to consider is that paraspinal muscle quality does not consistently show differences between low back pain patients and controls. And for this reason, it's hard to understand why and how it really matters for low back pain in general. One of the problems here is that muscle in particular has non-pathological confounders because it's affected by things like age and sex. With age, muscle naturally atrophies. It's hard to separate the effects of that from what is related directly to low back pain and what is not. And so here you can see we came up with like an interesting statistical method to kind of link all the levels of the lumbar spine to understand patterns of muscle atrophy from L1 to S1 to see if that was distinct from age. So if we look in our younger patients here at multifidus fat infiltration, as you go from the top to the bottom of the lumbar spine, red is our patient population and blue is our controls. We see that they kind of follow a similar pattern in the younger individuals. But then in our older individuals, we start to see that the patients deviate from this pattern and they have higher amount of fat infiltration throughout the lumbar spine. So this starts to tell us a little bit about how the effect from pain can separate from age. Furthermore, we're looking at how fat specifically distributes within muscle and how that might be specific to low back pain compared to things like age or sex. With males and females, there's natural differences in muscle fat infiltration that are problematic. But looking at the distribution of fat, we're able to see some pretty cool things. So Lucas over here, our trusty med student, he likes to plot fat from the lumbar spine muscles and really see if he can find patterns that are unique. And one of the things that he's working on right now that I think is cool is that he's looking at how fat in the paraspinal muscles, so all of them, in this case, we have psoas, erector spinae, and multifidus, how these fat patterns change as you radiate away from the center of rotation for the vertebral body. And what we see is that for all these muscles, so here we have the fat fraction patterns for multifidus, red is for erector spinae, and green is for psoas. They're highest closest to the middle of the spine, but then they kind of go down as you go away. And not a lot of people have looked into this. A lot of the muscle quality data really just focuses on fat percent only. And so this might give us a clue about how fat accumulates with a symptomatic spine compared to those that don't have it. So it'd be interesting to see how this compares with people with just age-related fat infiltration. And then another confounder is the effect of existing spinal pathology and how that affects muscle quality in the spine. And what our group has found is that the existence of in-plate irregularities has an effect. So looking at our chronic low back pain patients here at UCSF, if we separate them into individuals who have an existing in-plate pathology in the cartilage in-plate over here on the right versus those that do not, we see an uptick in the amount of multifidus fat infiltration in the lower lumbar spine compared to those that don't have pathology at L4, L5. So this study did see a significant association between local in-plate pathology and local changes in muscle quality, inferring that the worse muscle, muscle can hopefully be a target to be rehabilitative for these patients with spinal pathology to hopefully help mitigate their symptoms. And here's an example of two patients with or without in-plate damage, showing that these are pretty comparable patients in age, in gender, in ODI and VAS, but the one at the top with in-plate damage has double the muscle fat infiltration as the one on the bottom without in-plate damage. And so this work was in close collaboration with Aaron Fields, who gave us all the wisdom and expertise on in-plate pathology. Unfortunately, MRI can only tell us so much. So in recent time, I have collaborated with Brian Feely to understand what is going on in the tissue specifically. So we recently did a study taking muscle biopsies from disc herniation patients and seeing what is the cellular composition of these biopsies. And as we may expect, just looking at the cellular composition, we find that there's increased fat infiltration and fibrosis in muscle that's affected by denervation, likely from disc herniation. And taking this approach allows us to go beyond just what is the cellular composition. We can actually start to understand the regenerative potential of muscle, in which case the word FAP may have come up in the past, and you might be wondering, what is a FAP? Well, a FAP is a fibroadipogenic progenitor cell. Please don't ask me any questions about it, but it's a subset of resident muscle stem cells, and it's thought to be very important in muscle regeneration as well as the development of fibrosis and fat generation within the muscle. And so taking some rodents and letting them age naturally and looking at all the content of the FAP cells within different muscle groups throughout their body, the Feely lab has shown that in the rotator cuff and in the spinal muscles, they naturally develop way more of these FAPs in those muscle groups compared to other muscle groups in the body, showing that those could be good targets for regeneration of the muscle tissue that is affected. And then back to our disc herniation study, we also looked at the FAP content in the affected muscle from our disc herniation patients. And we found that they had a higher number of FAPs in their affected multifidi and satellite cells compared to control hamstring samples. And this kind of leads the way to how we think about muscle being degenerated in our spine patients and how we might be able to act biologically to maybe reverse it, and whether or not it has natural regenerative potential. And so right now we have a med student who's doing a prospective study on getting advanced imaging and getting muscle biopsies from both chronic low back pain patients and disc herniation patients to try to start teasing apart these mechanisms for how muscle is affected in our spine patient populations. And so going along this line, we want to further decipher how disc injury can relate to muscle degeneration and low back pain. And unfortunately, we can't really inflict disc herniation, obviously, on our poor human subjects, but mice make for a very good animal model. And so we are currently doing an animal study where we are inflicting a disc injury and then seeing the effect on paraspinal muscles. And here's a cool 7T MRI of some of our rodents after they have experienced a disc stab. And you can see on the disc injury side, there's a lot of darkness and lack of signal intensity of where the disc should be, kind of confirming that we succeeded. And all this work is being done by the Feely Lab and primarily Michael Davies, who is spearheading this project. And so this is only preliminary research on what occurred during the first 6 weeks following the injury, but already we see that the side with the disc injury has significant differences in muscle composition. So the most interesting thing is probably looking at how the fiber types are different between the affected disc injury muscles and the sham. And what we're seeing is that there's more transitional fibers and probably more type 2 fibers compared to the sham side. And this is kind of what we'd expect in a low back pain model. So the mice are behaving as we would hope. We're also seeing an increase in biomarkers for inflammation. So CD68 is a marker for macrophage activity. And we're seeing that in the affected muscle, it has more activity in macrophages, which is what you would expect if there's a disc injury that is leaking inflammatory contents onto the muscle. So this can begin to tell us why adjacent muscle might be affected by adjacent spinal pathology in our patient population. And then, of course, looking at FAPS, we see that in the muscles that are in our disc injury group in the rodents, that they also are increased in fat percent. So we are seeing that they have higher gene expression for both fibrotic and adipogenic factors, so leading to fibrosis and fat infiltration. And so we'll further explore this to see if we can intervene or not, or if there's regenerative therapies that might hinder the further development of this. And so moving on, I'm going to take like a real hairpin turn here, hopefully. But we are also doing a lot of in-clinic biomechanical assessments. And we've done a lot of work on spine biomechanics, looking at dynamic sagittal balance and trying to estimate spinal loading in a clinic setting. And so I will go over a little bit about what we've done in the past on that. And so mainly I'm going to be presenting the Issels Prize work that I completed as part of my postdoc last year, and where we're kind of taking that next. And so the reason why we care about in-clinic biomechanics for our spine patients is because of this fundamental concept for our spine surgery patients about the cone of economy and balance that goes back 30 odd years. And currently, it's thought that these patients need to have overall standing stability and sagittal balance to use the least amount of energy and muscular effort to amble about, and that spinal deformity impedes this. We find that when we correct sagittal balance with surgery, that it improves patient outcomes. And so the thought is improve sagittal balance, improve patients. But the thing is, radiology, alignment from radiology does not equal balance necessarily. Balance requires motion. Balance during movement requires concerted stability between the spine and the lower limbs to maintain center of pressure. So to really capture balance, we need to see how patients are compensating in regard to motion. And this is important in addition because of a recent study by our spine group looking at the effects of 10 minutes of walking in between repeated standing alignment scans in our spinal deformity patients. And 10 minutes alone had a significant effect on the standing sagittal vertical alignment, which is the horizontal distance between C7 and S1. And you can see that after 10 minutes, this patient has a very different sagittal balance than they had before the 10 minutes of walking. And I think this sort of alludes to the role that muscles play in these patients and why it's important to really think about things dynamically. And so we care about this because we want to improve outcomes for spine surgery. And one of the biggest post-surgical complications is proximal junctional kyphosis, which is a mechanical failure that occurs at the top or bottom of the spinal construct and requires a revision surgery. And people have been trying to understand what are risk factors that contribute to this risk of PJK. And recently, a lot of work is kind of inferring that movement really matters, and that our lack of understanding of dynamic stability in our spine patients is one of the factors for why PJK remains an unsolved problem. So during my postdoc, in collaboration with Rob Matthew, we developed an in-clinic assessment for patient-specific dynamic sagittal balance. We used the Microsoft Kinect to do markerless motion capture of the patients during their clinical visits. So they didn't have to take off their clothes. We didn't have to adhere markers to them. It took less than 5 minutes. And what we had them do was an unassisted sit-to-stand maneuver. So sit-to-stand in general is a very good test for low back pain patients. And it's because it's particularly difficult for low back pain patients. They have to go from a stable seated position to a stable standing position, all the while controlling their spine in between these two during the transfer, which can be very painful if you have a condition in your spine. And so after getting motion capture of their unassisted sit-to-stands, we can do biomechanical modeling to understand what are the kinematics, kinetics, and dynamics of their joints in the sagittal plane as they get out of this seated position. And this work, largely validated by Robert Matthew in physical therapy and rehab science, is shown that our non-invasive motion capture system has pretty high fidelity for this test. And he has done a lot of work comparing it to gold standard motion capture, as well as comparing the actual joint forces to joint forces that are generated from a motion analysis lab. There's Rob. So for this study, we looked at 15 adult spinal deformity patients before and after realignment surgery. And we compared them with 10 healthy controls. And we had them do unassisted sit-to-stand functional testing. And the things that we looked at for these patients included peak sagittal vertical axis, so the amount that their trunk leaned outward as they got out of the chair. So the maximum that their SVA became during the dynamic maneuver. We also looked at things like trunk momentum, forces throughout the spine, hip and knee, spinal extensor muscle force, range of motion of the hip and knee, energy of the hip and knee, and center of pressure. And we collected patient outcomes, radiographic SVA and PROs for spine. What we found in our patient cohort is that they improved for the most part in PROs, which is kind of what we wanted to find, because we want to see what is the natural change in biomechanics that occur with an otherwise not problematic surgery. Does it, if their standing balance improves, as it showed here in radiographic SVA, what's going on with their dynamic balance? Is it also improving? And so here's a video of a patient before and after surgery getting out of a chair. And this is their sagittal plane. And red is pre-surgery. They're much slower. And blue is post-surgery. And so they got out of the chair pretty quick after surgery, and they looked a lot less hindered than they were before surgery. And what we found is that with surgery, their peak SVA was significantly worse before surgery compared to our control population, as well as the relative ratio of hip and knee torque compared to the control population. But then following surgery, in our patients, these metrics were no longer different from the controls. And in fact, they kind of went down to the same level of the controls. This was extra interesting because our control population had a significant age difference, and they were younger than our adult spinal deformity patients. So it showed that, you know, with the spine surgery, for the most part, their dynamics became more similar to a younger, healthy population. And so another interesting thing that we found was that the center of pressure did not significantly change following surgery. And that was unexpected, because if you think about sagittal imbalance, you think about imbalance, you think about a non-optimal center of pressure. And what we found is that it's important to really look at the lower extremities, because they're compensating to maintain a center of pressure. That is one of the key findings that we found. And that we really need to think about the strategies throughout the kinetic chain that these patients are using in order to stabilize themselves with an unfavorable spinal condition, and how much energy they're using as a result. So center of pressure is maintained, but everything else is changed for these patients in order to keep standing upright. We did have one patient, or two patients actually, with proximal junctional kyphosis that we were able to kind of follow as case studies. And what we found with them, so this is comparing how they got in and out of the chair before the episode of PJK, and then before their revision surgery, and then after their revision surgery. And then what you see is they're pretty bad pre-surgically before the revision surgery. In that, here, I'll play that again. But then post-surgery, they kind of come back to what we would expect from our study. In that, and this shows the data kind of comparing this one patient to our controls. In that, before the PJK and after their surgery, the initial surgery, they already had levels that were higher than the controls. And then they had the episode of PJK, and it wasn't until the revision surgery that they improved to the control level like we would have expected. And so using this approach, we see that movement behaviors improve with the recovery. So we capture that data, and then we try to understand which variables associate with the condition. And then we see that movement phenotypes may predict post-operative risks. So implications for spinal loading and mechanical risk and low back pain. We see that with longitudinal changes in our spine surgery patients, there's reduced forces acting on the lumbar spine following spine surgery, and then that there's changes in compensatory lower limb dynamics. And then also dynamic sagittal balance comes with higher loads on the spine, hip, and knee. We did an additional study looking at how low back pain patients compare to our adult spinal deformity cohort. This was led by Priya. And what we found is that torso velocity is a main predictor for low back pain if you look at their mechanics. And that it wasn't different between our spinal deformity patients and our low back pain patients, but both were worse than our healthy controls. But DSVA was worse in our adult spinal deformity patients, as you would expect, and that this difference in DSVA really drove higher torque through the spine, hip, and knee that's seen in our surgery groups. So we think motion alone is great, but we need to really think about how everything contributes to loading through the body and how that can create risk for mechanical failure in different spine patient groups. And then lastly, we're expanding this work with a recent grant looking at muscle quality, like I just showed in the previous section, by taking surgery samples from our adult spinal deformity patients, as well as collecting data on surface EMG before and after surgery to understand how muscles in these patients might accelerate risk for PJK. And so this hasn't gotten started yet, but we hope to find some interesting things. And then lastly, I know I'm kind of running out of time, I want to talk a little bit about some digital health studies that we have going on. The reason The reason that we care about digital health, or should care about digital health, is that it's pretty important for orthopedics. For clinicians, digital health can provide knowledge of patient behavior between clinic visits. For patients, digital health can further inform and engage patients with their recovery and their rehabilitation. And for researchers, digital health can enable us to observe effects of a condition far beyond static imaging or patient-reported outcomes. Currently, we have a graduate student who's putting on IMUs on chronic low back pain patients to understand how their gait kinematics can be informative of both pain avoidance behaviors and muscle degeneration, and how we might be able to tease apart effects from both muscle degeneration and biobehavioral features to understand how chronic low back pain has an effect on these factors, and how we might think about the best treatment avenues for treating the condition based on pain, fear avoidance during walking, as well as muscle degeneration on trunk kinematics. And then down in sports medicine, we have ongoing work looking at shoulder function using the Connect. And this is spearheaded by, again, my collaborator, Rob Matthew. And for that, we're capturing this metric called reachable workspace, where patients move their arm into like 6 different directions, so that we can capture kind of a volumetric sphere that they're able to extend their arm into. And so you can see here, we have it separated into quadrants, but what's neat is that we can follow how much of this reachable workspace they're able to cover at different time points following surgery and between different patient groups. And we're working on a paper right now comparing different surgical approaches and how that affects their recovery via reachable workspace in a different manner. And what we're working on, though, in terms of evolving this work, is really getting out of the clinic with reachable workspace. Currently, we collect data in the clinic, which during COVID is like impossible, but we're using the Connect, and the Connect is great because it has pretty high quality and a lot less missing data as a result. But what if we want to start collecting reachable workspace out in the wild? We can do so using a phone. And 2 of the methods that we're working on developing are motion tracking using sensors. So at home, we can have patients hold a sensor and do reachable workspace and try to estimate it, or they can even just hold the phone because it itself is a sensor. But then a separate idea that we have is literally trying to use 2D video from phones or laptops or anything to try to use, to try to estimate what we get with the Connect, which the Connect does 3D depth mapping. It's a very specific device. But if we can start using neural nets and all these fancy algorithms in order to try to generate accurate motion profiles from video alone, that would be a very powerful tool, because we could then just have patient reported outcome apps over a phone and get biomechanics over video alone, and we can get a lot of longitudinal and meaningful data that way. And so this figure is from a group who's essentially done this for gait, and they show that, you can get a video, you can get some gait, and then you have to employ a lot of informatics to get reliable biomechanics. But this is far better than the current standard, which is, in clinic or in lab motion capture, pretty arduous post-processing in order to get the report. So this is something we're working on because we think that for telehealth purposes, this could be a pretty powerful tool. And then lastly, I have a collaboration with a digital health company, which has since become very large. I think I started consulting with them when they had 20 people, and now they have 500. But they have a digital care plan for chronic musculoskeletal pain, primarily low back pain. And this has been a really eye-opening research collaboration between academic medicine and industry. So I've done a couple projects with them, taking their mountains of patient data. They currently have like a database of 50,000, I think, MSK subjects, and then doing their phone app over 12 weeks. And what's been really cool about this is that we can do really interesting data science to understand how patient engagement really matters for improving outcomes. Also, we can do neat things like phenotyping based on baseline factors to understand who becomes a responder to the digital care app and who doesn't. And you can see here, this is from a recent study that we published on 10,000 patients, that we were able to separate. So this is their like VAS over a 12-week period of time. And for the most part, doing the digital care app, they had an improvement in VAS. But we were able to find like 3 distinct patient groups of who was like a high responder, a low responder, and at what rate they responded based on things like gender, sex, BMI, and other sort of baseline factors. So using this big data approach and has been really interesting. And so that's kind of the whole gamut. But the key points that I want to make is that when we think about these problems, underlying pathology matters. And I know that to this group, that's not surprising, but I think when we interact with our collaborators in neurosurgery or even physical therapy, you know, this is something to really be considered, is that the role of imaging and underlying pathology can really tell us a lot about mechanisms, because it has an effect on tissue health, on muscle health, on patient-specific biomechanical behavior, and therefore choosing effective care modalities. And we're trying to really clarify this as well with the whole backpack study. And then furthermore, that patient-specific movement behaviors can both aid our understanding of mechanisms linking specific conditions to pain and disability, as well as it can be used to phenotype patients. And then lastly, patient engagement is very important. And patient engagement with care and recovery is integral in order for us to have lasting improvement in orthopedic conditions with chronic pain. And I think that that's something that digital health can really help with. And that's something that I hope we can advance in our own research and patient care here. And so that is it. I acknowledge most of the specific collaborators throughout the talk, but these are all of our funding agencies who have provided grants and fellowships, and without them, none of this would be possible. And I also want to thank all the clinicians that I have bothered at some point to get patients and to collaborate on research projects. Without that kind of synergy, I don't think we'd be able to do all the cool things we do in this department. And that's it.
Great. Thanks so much. That was an excellent overview and a lot of really interesting work. And if anybody has questions for Dr. Bailey, please feel free to unmute yourself or raise your hand, but feel free to just unmute yourself and ask away.
Jeannie, this is Einor Sawyer. I don't know if you can hear me okay.
Yeah.
Yeah, great. Thank you so much. That's an impressive body of work and a great overview. At the UC Space Health Center, we're working with NASA on countermeasures, particularly against muscle wasting and bone wasting in space. And I was wondering if you could just elaborate a little bit about the association of the multifidus fibrotic component that's been shown to be associated with osteoporosis and osteopenia in the vertebral bodies. I think it's a really interesting association that might play into some of your work going forward. And I think it supports Wendy Katzman's Stand Tall program as well.
Yeah, so it sounds like a lot of that work has been done in our clinical populations, right? Not the astronauts.
Yeah, that's right.
Yeah, so I mean, I think that would be really interesting. I think we've been trying to get, so working with NASA right now, we actually are starting a surveillance, I know that's a really scary word, program in order to get pre-flight MRIs. And we're actually fighting to do a lot of the same protocols that we're doing with like backpack with NASA in order for us to phenotype pathology and muscle health using better sequences than we did for the NASA study. And hopefully with that, we can start to really look at those factors. Because I agree, I think that like fibrosis is really important and we have ignored it. And for bone health, that undoubtedly is affected by microgravity. We didn't necessarily see any changes in like vertebral geometry, but we were not able to look at bone density. So I do think that that is an overlooked factor that's probably very important.
Great, thank you.
Hey, Jeannie, congratulations. I also want to commend your broad body of exciting work. My question is also about the spaceflight study, and in particular, the similarities between astronauts and terrestrial populations. The common perception, I think, is that spaceflight is just this non-physiologic event, but it's really striking to see that many of your findings in the astronauts mimic what we see in clinical populations. And so does that suggest that really spaceflight is like a model of supraphysiologic aging or accelerated aging? Or are there, do your data reveal patterns of degeneration, for example, in the muscles and vertebrae and discs, that are unique to astronauts during spaceflight that you don't see in clinical populations on Earth?
That's a great question. I don't think that it's accelerating aging because we see recovery in a lot of the tissues in people who are unaffected. What I guess I think is that it provides a very good perturbance of spinal stability for us to see how things like muscle quality and things like disc pathology can inhibit one's ability to recover with that change in biomechanics. And I think that that might also inform us a little bit about what creates risk for disc injury in our patient population, or what creates risk for chronicity of pain, you know, because it's taking someone who has pathologies that we can't always make sense of here in a cross-sectional cohort, but suddenly if we change their spinal stability, we have poor outcomes if they have that pre-existing pathology. I think that's really interesting. And it's almost like more informative of how we think about spinal pathology and spine problems on Earth than astronauts.
Thank you.
Hey, Jeannie, Sig here, terrific talk, and I just want to let everybody know that the awards that Drew alluded to, the Issels Prize, Jeannie's won that twice now, and that's one of the highest rated prizes in the spine surgery literature, spine conferences. To that end, we're certainly looking forward in a new spine center to having more of you there looking at our pre-ops and post-ops. It's nice to see that you're able to measure quantifiable change in some of these motions. And I think there's so much more we can do with better space in a new area. I wanted to get to the issue of Dubusse, and as you know, you and I just finished a chapter on balance versus alignment. And what are your thoughts about measuring balance? Because the fundamental concept here, as you know, is that balance is dynamic and alignment is radiographic. And as surgeons, we spend a lot of time talking about alignment, and that's the endpoint we can control with surgery. But how do we improve balance? And what else goes into balance? Is that something we can improve?
Yeah, I think with this upcoming CDMI project on muscle biopsy in that exact same Issels study, like essentially we're repeating the Issels study, but adding SEMG to understand muscle activation before and after surgery, as well as muscle biopsy from surgery. I think understanding the natural stabilizers of the spine and whether they are pre-existing risk factors for imbalance is gonna, I don't think anyone's really done it that well. I mean, some people have looked at some MRI, but I think if we can really understand how muscle is affecting patient alignment and balance, then that can really drive things forward potentially.
It looks like Dr. Beanie has his hand up.
Yes, but I want to let the spine folks have their say. Listen, Jeannie, this is fantastic. You know what I think is one of the biggest contributions you made is it brought attention to the fact that it may not be muscle strength that's important for stability. It may be its conditioning. In other words, how long you can struggle for. Because those images you showed around, well, I guess it wasn't in your lab necessarily, but the idea that fatigue can lead to changes in kinematics, I think is really critical thinking. I'm not sure a lot of people have looked at it that way, and not in arthroplasty for sure. The other thing is the concept you brought up about digital therapeutics. For anybody interested in working with some of these companies or developing your own programs, there is definitely a move towards getting these reimbursed, and there are concepts that sooner or later there will actually be formularies of accepted digital therapeutic options, which is fueling a great deal of investment in this area. And in Germany already there are codes available for digital therapeutics to be prescribed, like one might prescribe physical therapy, one might prescribe medication. So tons of really good stuff happening around this space that will enable the ability to actually implement it in real patients. So really fantastic work, and I look forward to seeing more.
Thanks.
Jeannie, no time for a question, but just thanks for putting it all together, and enjoy working with you, and a lot of great tools to answer some questions. So look forward to the future. Congratulations.
Thank you. I'll try and do more hip stuff.
Excellent.
All right.
Jeannie, have you or anybody else looked at the innervations of the muscle, or if the muscle, the nerves are degenerated in the space flight or afterwards, or is that the case also in the old people you are looking at in the normal population?
So we can't look at that in the astronauts currently, but it is like kind of a working hypothesis that maybe their muscles are being de-innervated by changes in alignment in space. But we are looking at things like de-innervation in the muscle biopsies actually. And so we are trying to understand how de-innervation is affecting muscle health and biomechanical function from a mechanistic point of view. But yeah, in the astronauts, it's merely a hypothesis.
All right. I think with that, we'll probably look to wrap up. But Jeannie, thanks again so much. And we'll see you all next Wednesday for Dr. Heather Roberts.
Great job, Jeannie. Well done.